What makes cancer cells cancer is that the cells figure out a way to grow without control, right? Like that's our normal cells, but it's able to grow without any control, bypassing all the normal regulatory mechanisms in our body.
And the thing that struck them was how many patients they're seeing with young onset CRC. And I would love your take on it. Like, do you have any hypotheses or early data to suggest what is happening and why we're seeing an uptake in young onset CRC? Welcome to The Patient from Hell, the show where we discuss real stories, expert insights, and build a community that every cancer patient deserves. I'm your host, Samira Daswani, a bioengineer, an entrepreneur, and a cancer survivor. Today, we're diving into the world of colorectal cancer with Dr. Tejas Jayakrishnan, or TJ, an oncologist from Dana-Farber's Young-Onset CRC group. In this episode, we explore why younger people are getting colorectal cancer, when should someone get screened, and what tools can patients and clinicians use to make decisions. TJ sheds light on the latest research happening in the field and his vision for the future. Let's get started. Dr. TJ, welcome to the show.
Hi, Samira. So excited to be here and, get connected with your listeners. Really looking forward to our discussion. I'm Dr. Jayakrishnan. As Samira mentioned, I'm one oncologist. I focus on gastrointestinal oncology, meaning cancers affecting our intestinal tract, anyway from the food pipe or the esophagus to the stomach and colon are the areas I deal with mostly. I have a special research and clinical interest in young-onset colorectal cancers. That is the younger individuals developing colorectal cancer, as we are seeing increasing incidence of that, and I have a special clinical and research interest in that as well.
TJ, can we start with what made you enter the field of oncology?
Yeah, definitely. I think as most oncologists, we enter the field because of the passion for really understanding this disease and figuring out ways to tackle it. We are dealing with a group of patients who are at a stage in their life where they are like really a lot of times people have never expected that something like this would happen. There are not a lot of risk factors for some of the cancers that we see. What are the best ways to deal with it? And it's a really, really difficult stage in their lives. And I really was able to connect with people, patients. And I think being part of their life at this critical juncture is very meaningful to me, and thought that's something which I can really focus my life and energy on. And it's also the intellectual curiosity element of it. What makes cancer cells cancer is that the cells figure out a way to grow without control, right? Like that's our normal cells, but it's able to grow without any control, bypassing all the normal regulatory mechanisms in our body. And that's what makes treating cancer challenging too, is because it's very similar to other normal cells. And therefore, a lot of treatments that we use for against cancer cause a lot of side effects because it causes damage to our normal cells as well. So it's a very challenging disease to treat, and therefore, for someone like me who is interested in research and academics, it comes with a lot of intellectual stimulation in terms of we need to figure out better ways to treat it, and so it's like a really I think it's a rewarding field in both ways, in terms of taking care of patients at this stage in their life, and also in terms of the biology, understanding the reasons why cancer cells are developing and what are the ways that we can stop it from growing and spreading to other organs.
TJ, I know this is a little off script, but I just came back from ONS. We had a poster there.
Okay.
And I was talking to a couple of the nurses there, and I was asking them what has been their biggest learning, at least day one, day two of the Congress. And the
Sure.
thing that they said was, and that these are, overall oncology nurses practicing across the country, primarily in the community setting. And the thing that struck them was how many patients they're seeing with young onset CRC. And I would love your take on it. Like, do you have any hypotheses or early data to suggest what is happening and why we're seeing an uptake in young onset CRC?
Yeah, it's really an epidemic. We're seeing more and more younger people developing colorectal cancers. Um, we do think that, it's related to environmental factors to a large extent. When we study the colorectal cancer incidence, this uptick has been happening mostly for individuals born after the 1950s. So we call it birth cohort effect. That's when we start really seeing that like increasing incidence of young onset colorectal cancers. There are a lot of things that have changed in those last 50 years. The diet has changed. There's more westernization, more preservatives in the food. Um, there are microplastics. There is a lot of like environmental pollution, like exposures. It's really unclear it's hard to pinpoint any one etiological risk factors, because there have been a lot of like lifestyle changes and environmental changes in those last 50 years. But that's what our research is like, trying to understand, can we investigate how any of these factors, whether a diet or environmental factors, may be altering our biology, and see if we can understand any signatures, is what we call it. Like our body is constantly undergoing chemical reactions. It's called metabolism. So are there signatures or features that we can identify from the metabolites produced in our body, or the microorganisms? Our intestine is full of microorganisms. There is healthy microbes and unhealthy microorganisms. And we are understanding that as cancer develops, there is a shift from microorganisms from unhealthy to healthy side. So we are looking back into the stool specimens of people who have developed cancer at younger age groups to understand, are there signatures from the microbes that are associated with young onset colorectal cancer, with the idea that the environmental factors that are influencing the development of cancer may be altering the microbes and the metabolism in the body, and maybe we can use that to detect or identify people who are at higher risk for developing cancer. But in terms of what exactly causing it, again, right? Like it's hard to know, but we know that it's environmental, and the reason we say that is because genetically, in terms of the genomic and the mutation profile for young versus older people, there is not a lot of difference. And so that's why it's something not like a genetic change that has happened to human beings, but more so some environmental external factor that is causing this.
And DJ, sorry, maybe not why is not the right question. Is the uptake happening across tumor types or just CRC?
So, I mean, CRC is the type of cancer where it's most pronounced, but and in early onset in GI cancers in general, like especially in the US, gastrointestinal cancers are the most rapidly rising early onset cancers. We do see increasing incidence in breast cancers. Also, I think there are studies that are showing that in lung cancers also there's increase, which we would expect, because if environmental factors are causing this, then it should have an effect on other cancers also. But it's also very mixed things, because like the diet I mentioned, our intestine is the organ that is exposed to diet right away. So there could be differences in the risk for different organs to these posed by these environmental exposures.
Very interesting.
Yeah. And another one more thing I would say is, the initial studies showed that this is most prominent in Western countries, but more recent data shows that it is also appearing in even other countries, including in Asian countries, South America, and other countries. The thing to keep in mind is some other countries don't have screening programs for colon cancer for later age groups. So the uptick is across the different age groups, as opposed to, say, in the United States, the older age group, because of the screening, and mostly because of screening, the colon cancer incidence has come down. In the younger age groups, we did not have screening, and now we are seeing increasing incidence of cancers?
We're so far off topic, but I really want to ask this question too.
Definitely.
The thing that I learned, so I'm a survivor. I got diagnosed after I turned 30. A week after I turned 30, I got diagnosed with triple positive breast cancer. And anyway, all this to say that I'm in remission, NED, all that fun stuff. But what happened maybe a year and a half ago was my iron levels, ferritin levels tanked, which triggered a whole workup for CRC. So I ended up going through at least some of the early CRC protocols. And the thing that very naively I didn't realize was if you did a PET scan or you did imaging, that doesn't actually help in the workup for CRC. You really need to go inside. You need to do the endoscopy and the colonoscopy for us to get anything. Can you address that a little bit in terms of like why modalities of imaging don't quite work for colorectal cancer, and then what the screening protocol is today?
Yeah, so that's like a very, very important point that you bring up. Yes, so to address the first part of your question about the PET scan, so any scanning modalities would only detect cancers or any tumors after they increase beyond a particular cutoff. So like whether it could be like 5 millimeter, 1 centimeter, depending on the technique that you're using. There are different cutoffs, size cutoffs for any cancer to be picked up in a scan. Number one. Number two, PET scan, for instance, you mentioned, detect any abnormal areas or tissues that is more active than the others. And sometimes cancer cells, even if they're active, they may not actually always show up on a PET scan. So that's the false negative part of false negative in the PET scan. And so and in intestinal tract especially, what you will see is, so intestinal tract, and you would see in a PET scan, other organs like the brain are very like metabolically active. So if you get a PET scan, there will be a lot of areas in the intestine that would like light up anyway. So it will be hard to so it's not just a matter of not being able to detect, it's also a matter of like seeing things but not knowing that is indeed cancer. And so the way to screen for colon cancer is there are multiple modalities. We'll be discussing today the stool-based testing, and there are direct visualization testing, which is basically inserting an endoscopy, sigmoidoscopy, which goes through the lower part of the intestine, to colonoscopy, which goes throughout the intestine to look for any tumors or polyps. That also, the difference is in the stool-based test, you see it actually essentially detects blood or sometimes tumor-associated DNA in some of the stool-based testing. But that does any positivity in those stool-based tests only suggests that there is possible cancer. Ultimately, to diagnose, you do need an endoscopic evaluation. You also asked about the screening criteria. So an average risk individual, so someone without familial risk factors for cancer, someone with an inflammatory bowel disease, that are conditions like Crohn's disease or ulcerative colitis, the standard screening is 45 or above. So everyone, once they reach 45 years or above, should start colon cancer screening through any of the different modalities. There are different frequencies based on the type of modality you choose, but you should start at 45. It used to be 50 years, but in 2021, the United States Preventative Service Task Force decreased the age cutoff to 45. Another thing to keep in mind, and I'll finish there, is that you mentioned about iron deficiency anemia. Very important that we need to spread awareness about this situation, because screening starts at 45, but anyone with say iron deficiency anemia, having blood in stool, this abdominal pain, or that is unexplained abdominal pain that is persisting over days or weeks, or sudden change in caliber in the stool. Someone having a regular bowel movements every day suddenly starts feeling constipated, or the stool becomes thinner, or starting to have difficulty having bowel movements, or even alteration the other way around, start having a lot of loose stools, can indicate obstruction. So any sudden changes in bowel habits, blood in stool, iron deficiency, anemia should prompt evaluation without any delay. So those are people who needs evaluation earlier on. Um, and and I would say, definitely, you should anyone should speak with their primary care physician, make sure they are appropriately screened for different cancers.
Thank you for that. I really
Of
appreciate
course.
you covering that.
Yeah.
And for entertaining my deviations.
Of course, I'm glad you were able to be evaluated, and hopefully everything is okay.
Everything was fine. They found a polyp. It's all clean. I'm on a 5-year repeat thing for
Yes.
now.
You
The
need to
entire world knows about my colonoscopy experience. Anyway, outside of that comment, maybe we can use that to transition into the study that you reviewed.
Yes.
Maybe you can just start by telling us what was the study, just an overall kind of what did the research team look at, why were they looking at it, and why is it important?
Yeah, very important study, and great job both you and your team from selecting this study. As I mentioned, screening is the primary modality for detecting cancers early. However, even in countries like US with an existing screening program, a lot of people don't undergo screening. In US, the current statistics is about 70% of people who fit the criteria for screening do undergo colon cancer screening, which is an improvement from about 50% from a few years ago. In younger individuals, 45 to 50 years, it's still low. Even after 2021, once that age cutoff was changed, vast majority of people in that age group do not get screening, and we are doing there are efforts going on to improve the screening. So this study asks an important question as to whether we can use decision aids like visual methods, meaning description of what a colonoscopy is, or fit testing, which is basically testing the stool for blood as different screening modality. So describing those techniques in the form of a visual aid versus using a quantitative aid, meaning giving the actual numbers in terms of someone's risk for kind of colon cancer, the effectiveness of the screening programs, if that would help improve someone's interest in undergoing screening and subsequently undergoing the screening. So that's what the overall idea of the study was. And they selected patients who who fit the criteria for screening. So there were people who should have undergone screening but have not undergone screening yet. It was a randomized clinical trial. They randomly divided people into two groups. One group who had the visual information aids versus the other group who got the quantitative aids. And then there were different time points before introduction of these aids versus afterwards, and seeing their understanding and intent to undergo screening changed or not. And then they followed these people up after 6 months to see if there were any differences in the number of people who underwent screening in either of those modalities. What the study did not address was whether using any sort of any of these explanations or teaching aids did improve. What if you did not do that? Did it help at all? So that is a question that the study did not answer, but it looked at the two different modalities.
And what did they find?
So they actually found that both of the tools, the visual as well as the quantitative aid, did improve the intention to undergo screening for both the groups that were studied. Both for the fecal immunohistochemistry, that is the FIT testing, and also for the colonoscopy-based testing. So there were increased intent. They also showed that people had less concerns over either of those modalities after they were introduced or they were given explanations about the screening programs. They interestingly found that when you use the quantitative aids, meaning the numerical data about the screening program, there was a increased interest in undergoing the FIT-based testing. So I think people who initially were hesitant, once they see these explanations, they become more comfortable doing these tests. and it seems to be more pronounced for the FIT screening program. And when you used the quantitative, the number was used. Maybe perhaps because people have more concerns about the stool-based testing as opposed to the colonoscopy-based testing. So that changed. What was interesting was, but when you look at I mentioned 6 months follow-up. When they followed up all these patients with a phone call, all the individuals, and tried to find out, did you actually undergo screening? There was no difference between whether you were given teaching using a visual aid versus like a actual like numerical sort of an aid. So equal proportions of people underwent screening on both groups, about a third, without a significant difference on what modality they used, whether or not they used one way or the other. But I think the takeaway is not that the quantitative methods did not help. I think the takeaway is that the using either of these aids did increase the chances of people undergoing screening. And these were a group of people I mentioned who did not have screening prior to this. So it did help in that way. Number two is we also worry that actually providing numerical data may create a false sense of reassurance sometimes. So it can actually, especially in decisions like this, people can actually get a false sense of comfort in knowing that, okay, this is lower than what I expected my risk of colon cancer is, therefore I don't need to undergo screening. So it did not show any decrease. So it did not show any decrease, overall an improvement, but it looks like visual method versus the numeric method are both somewhat similar in how that they impacted the interest and uptake for the screening.
TJ, in your clinical practice, so wearing a clinical hat, do you use physician aids?
Yes, I actually do. I want to say, again, combination of both, right? Like, so I think in a way the study kind of like supports that, what a lot of us clinicians do. Especially when I'm explaining to a patient about a particular type of cancer diagnosis, I try to draw it out to show what organ is affected, what the stage of the cancer means. There are different stages to cancer, so I try to actually like to draw it out to show. And there are sometimes, now we have computers in all the patient rooms, so it's easy to pull up some of the images too. So I use the visual aids, but I also use numbers quite a bit. In cancer, we have to treatment. We have to talk about numbers all the time. As you've experienced, like progression, overall survival, response to treatment, the toxicity rates. So there are a lot of different things that we have to talk about. And so I have to use numbers. I also use the same, sometimes people, I try to tailor it by what patients want. Sometimes people would want more numerical data. So in that case, I would explain those numbers. But I always tell patients that, what we understand for the studies are all averages. So, we cannot always apply that to an individual patient, because we have to put different things in context. So, and, people come, a lot of times people do come, knowing a lot of some of these numbers. So I think my role oftentimes is to try to help navigate, are we looking at the correct study, correct comparison, correct type of cancers and things like that. So, yeah.
TJ, that fascinates me. Can we talk about that? How often are patients coming in knowing the numbers, or at least knowing some version of the numbers?
Yeah, I mean, I would say not very often, so it's not very often, but I think a lot of times what people come up with is, you may have seen, there are rare subsets of colon cancer which could have 100% response to, say, immunotherapy, and that's all over the media, released in the studies. So sometimes people may come up with numbers, but that may not be applicable to them right away. But so that's one extent. And so then in that case, I have to redirect, kind of explain that this is the type of tumor that we're dealing with, so the numbers are slightly different. But people do come up with numbers in terms of the survival statistics. Like we in cancer, what is the life expectancy? What have we found out either from like searching on Google quickly, or sometimes people have family members. I mentioned a lot of patients I see belong to younger age groups, so they may have had either family members or friends, or even friends who are in like pharmaceutical companies even. So they're coming with actual hard data from studies. So not very common. I do see people from all backgrounds, but there are people who come like knowing some of these numbers. And so in those situations, when it is like specific to their cancer, I still have to kind of reinforce the fact that these are averages. And again, different treatment regimens, and there are different things that we need to consider before we like assign a number. And I don't think we cannot always assign a number. We always need to see how someone responds to treatment before getting an idea about what the long-term outcome is going to be.
I was asking that question partly because I wanted to talk a little bit about health literacy.
Yes.
Because I'm sure there are definitions out there, but in my very sort of limited patient experience, what I found was that one, literacy kind of grows over time, right? Like there's almost like I start out with a very low understanding of what's going on. And then as I'm a patient for a longer duration of time, you kind of almost have to learn. It's almost a forced learning, right? Because there's so much new language coming your way that you just have to kind of almost upskill.
Absolutely,
so when you're upskilling, there's like language and translation. It's almost like, what is CRC? What is overall survival? That's like one type of literacy. The second field is almost mathematical. But the thing that I'd worked in oncology before, so slight different background prior to being a patient. So I walked in knowing what a Kaplan-Meier curve is. I walked in knowing OS, PFS. I sort of had at least a baseline understanding of how to read clinical study papers.
Yes.
And like look at an AE table and understand what that's saying. So you kind of almost need just terminology, cancer 101 stuff, and then you need to learn almost statistics. So how often do you find yourself having to deal with one or both? And part two of that question is, how often are you having to change almost your own depth of education as that patient is kind of getting more and more activated?
Yeah, I'll address it the last part first in terms of like how much like I have to adapt. It's very like you said, you have to it's like a dynamic process, the relationship with the patient. Even my own decision, it's a dynamic process, like because like statistics also like change over time, like the clinical trial, the Kaplan-Meier curves, the survival outcomes are a select group of patients who met all the eligibility criteria for undergoing the study. And then there's also like real world data, the long-term outcomes from like retrospective or like other observational studies that show outcomes from those analysis. So we have to look at a combination of different things. And if someone we expect to have a good outcome but is having response that we are not kind of expecting, then we have to like look at what are the reasons for that and make changes. And I think like most of us like in oncology always like at the very beginning itself, when we see a patient or when we start a patient on a treatment, we're always thinking about what's our backup plan too if this does not work, whether if the cancer figures out a way to grow out of it, or if the toxicity, because you're always trying to balance those two elements, right? You're trying to attack the cancer but also make sure the toxicity is well managed and the person you're treating has a good quality of life. And managing balance those two aspects. So we have to constantly adjust, make modifications. And we are also looking at data in terms of, if you dose modify what are the outcomes? Does the outcome get impacted by adjustment of the toxicity? There are like studies related to that also. So we are always looking into those. And then the other part of what you mentioned is, again, throughout this discussion, like a person's understanding of numbers, and even like numbers and statistics in general, and also the cancer related numbers become important. And I try to like gauge, talking to there are certain basic facts about the cancer staging, outcomes overall. I try to communicate over the clinical visits, but in terms of more specific details, in terms of the response, specific outcomes with regards to a treatment, and the nitty-gritty in terms of the Kaplan-Meier curves and such, I have a discussion with the patients about how much they want to know, and then go from there. But I really like open up that to them, because I think someone, it's your body. You need to understand, what is the best case scenario that you're looking at, what's the worst case scenario, what are the averages, and so I do try to like explain those aspects. Sorry, were you going to say something else?
No, I was going to ask you to tie it back to young onset CRC.
Yes.
Because my question was going to be, in a world, I imagine, I don't know young onset CRC research very, very well, but I imagine that the research body there is relatively skinny as compared to kind of average age CRC, right? So in a world where data is scanty, how do you handle it? Because there we don't really have a
So right. So as of now, the treatment for the cancer, the young-onset colorectal cancer, are similar to someone who's diagnosed at a later age group. So the management are similar, and the within the age groups, or in different studies, there's a broad range of ages. But someone in their 30s would probably not included in some of these older studies. But what we see is like there's also, most younger people do not have other medical problems like that, that would impact their ability to tolerate the treatment. And so we are oftentimes able to use more intensive treatments or combination of different treatments. So that's definitely there. And but you're certainly right. The outcomes may not be the same, and so we are definitely studies ongoing in our own center. So the Dana-Farber Young-Onset Colorectal Cancer Center, what we are doing is we have a long-term biobank in order to exactly to address these questions, right? Like one part I mentioned was understanding the reasons. What are the microbial features, the metabolomics, blood-based changes, genomics? So that's one group of studies. But we also prospectively longitudinally collect data from young onset patients, if they agree, and most people are actually interested in participating in research, to collect the data to understand the responses to treatment. And we have, as we get more data, we are also like designing studies so we can look back to see where we need to make changes. The other side of the things is also, unique aspects of young onset cancer, things related to, like fertility, reproductive issues, sexual health. People are dealing with issues related to work, career, family dynamics. So psychological, mental health. So a lot of additional aspects to treating a young person with cancer that is not just limited to addressing cancer. So at our Young Onset Colorectal Cancer Center, we have a coordinator who would meet with a young patient when they walk in through the door, kind of explain all the resources that are available, including clinical trials and studies that they may be interested in. And they monitor the needs, and there's a dedicated social worker who is able to work with the patient. So it's a very multidisciplinary team. So that's what I was trying to get at, is that, there's a part there's a role for oncologists like me, and we are trying to see how we can improve the outcomes. But then it's also like a multidisciplinary for cancer in general, but specifically for young people because of a lot of unique aspects to it, family, career, psychosocial aspects. So
Thank you. That was
Yeah,
really, really
definitely.
helpful.
Yes.
The only thing that was I was thinking about while hearing you describe that is, so Dr. Kim Yang has been on the show, and she's the one that connected us, and
Yes.
I've heard some version of what you're talking about from her before. And the thing that's always stood out to me is Dana-Farber is so far ahead of what I imagine the baseline is across the country. So if you are a AYA patient going through treatment somewhere else and you don't have access to those kinds of resources, I imagine it can feel pretty isolating is probably the lowest form of emotional support, I
Absolutely.
guess. But I do imagine it feels pretty isolating because you're such an outlier on so many dimensions
Absolutely.
that
Yes.
I'm actually very hopeful for all the work that you guys are doing. It becomes almost a model for the country and for different
And
institutions. But I'm hoping.
yes, and definitely, definitely, kudos to Dr. Ng's vision and recognizing this as a challenge at the very beginning of it, in setting up this center. As she probably mentioned to you in the podcast, I think the team did a study initially to kind of understand what are the unique challenges and really model the Young-Onset Colorectal Cancer Center based on that. And therefore, like for someone like me with active interest, it's like a really good environment to continue to build on that, continue to work, focus on what is important in taking care of the patients. But I also want to mention one thing that you mentioned in terms of people who may be in other parts of the country or the US. A lot of programs that we offer are also online. And there are several resources in our Young-Onset Colorectal Cancer Center webpage that would be available to patients anywhere. They don't necessarily need to be part of the Dana-Farber Cancer Center. We are, of course, happy to see anyone want to come over for any additional questions or consultation. But a lot of resources are available online too. That's something we offer.
All right, DJ, I'm watching the clock, and I think we're coming close to being done. So my question for you is going to be more future-oriented.
Yes.
You have a magic wand. You cannot get rid of cancer. I'm sorry. The answer will be
Wait,
easy.
that's maybe one day we will.
Maybe just in my magic wand, if I ask you that question, it's just not a good response. So magic wand, you can do anything, you can change anything. Let's constrain it to CRC. 5 years from now, what in your magic wand universe has changed?
I really think about two. There's not one thing I can really say. There are really two things that I grapple with every day. One is the young onset colorectal cancer situation, right? And I see a lot of people who have the first screening colonoscopy and then get diagnosed with cancer, and that is stage 4 sometimes. You get diagnosed with cancer without any symptoms and get a scan, there may be cancer in other parts of the body. It's localized. So sometimes, let's say it's localized, undergo surgery, but it's spread to lymph nodes and you do need chemotherapy afterwards. So one dream I have is that, really identifying through our microbiome, metabolomic analysis, trying to identify those signatures that can really help us in risk stratified screening. If you can identify strategies, and there are others working on it too. It's a combination of the environmental factors with the host or the genomics. But can we come up with a signature that we can, that could be easily deployed? The fit-based, there are several screening modalities like ctDNA, stool-based testing, and things like that. And the question is how effective they are, and is it cost effective? But I think incorporating some of these additional aspects, which take into considerations someone's host metabolism and microbiome, could be helpful. So really figuring out ways to detect cancer early. That's number one. The number two would be really, even if once the cancer is diagnosed, right? We need ways to treat it better. And I mentioned about the genetic conditions, and there are certain genetic conditions called microsatellite instability or Lynch syndrome associated tumors that has a high response rate to immunotherapy. Vast majority of colon cancers or rectal cancers do not actually respond to immunotherapy yet. We are finding some newer agents that are showing promise, but vast majority don't. So my 5 years from now, like my second dream would be that we are able to like really come up with combination immunotherapies that could be like really effective for that particular subset, microsatellite stable type of colon cancer, rectal cancers, because the other subtypes do have like we hear about 100% response rates with immunotherapy, but vast majority of people don't get it, and vast majority of younger people have that subset, microsatellite stable colon cancer. So really getting a breakthrough for in terms of treatments for that subset of patients. So those are my two things. And I would also would like to again cannot not emphasize the fact that you can only have screening modalities can be fit only to a certain extent. The most important thing is recognizing the symptoms, being aware of the symptoms, getting diagnostic colonoscopy, like you mentioned, right? Like iron deficiency, anemia, bleeding, alteration of bowel movements, getting evaluated, discussing with your physician at that time point to avoid any delay in the diagnosis. So that would be the other important thing. Right now I mentioned 70% is the screening rate. So hopefully we can get it to 100%.
I appreciate the very, very, I was going to say overachieving 5-year plan you have, but yes. I'm in full support of it. That would be kind of amazing.
Definitely. Thank you. Yeah, it aligns with my career plan. When you start as a academic oncologist, you have to have this career development plan. So this is actually in alignment with my own career plan. So it's not,
right.
It is too optimistic, but we have to start somewhere, right? And
I love it. And maybe 5 years from now, we'll have you back here to talk about the 3 things and where you are.
Definitely. Yes. I look forward to that.
I appreciate you coming on our show. I appreciate you sharing all the insights. And I am sure this is going to help a lot of patients and families. So thank you.
Of course. Thank you. If there are any follow-up questions from any of your listeners, I'm happy to address it any time. And I really enjoyed this discussion, like the questions. There were a few items I come up with, that I really want to make sure the audience understands. And I think your questions were I really appreciate your questions. And yeah, thank you for having me.
Thank you, Tejas.
Of course.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors. This episode was supported by an award from the Patient-Centered Outcomes Research Institute.